Okay, so yeah, I'll try and reflect on sort of the NHS as a whole, and I'll try not to speak for too long so we can get to the Q&A section. And as Laurie alluded to, I'll try and speak about it from both the policy world in Westminster, in which I'm working in at the moment, as well as the practice world of frontline medicine and working in the emergency room. So the way I'll do this is I'll sort of outline what I see as the problem and the challenge for the health service, what impact that has, what the goal of policymaking should be, and then how can we get there. Thinking through that and then sort of outlining a few different trajectories for the future of the health service, some more desirable than others, and then thinking about how we take sort of the desirable route if we agree on one. So maybe that will be quite a nice sort of moment to segue into a discussion with the rest of you. Right, so for the NHS, I think has a dual challenge, and sometimes these two things are muddled up. There's the immediate term or short-term crisis, and how we mitigate that crisis. And then there's the longer-term challenge to the health service that's been there for a while, but every now and again comes in waves of popularity about sort of that 5-10 year plan of how well is the health service keeping up with demography and changes in our epidemiology. So let's take each of those in turn. So the short-term challenge, the crisis mitigation, this is almost what I would describe as a damage limitation scenario, sadly. The problem here is the ones that you see in the headlines every morning, really. 1 in 4 ambulances are waiting over an hour to get to someone who might have a heart attack or might have had a stroke, or 7 million people are waiting for non-emergency treatment in a hospital. These are the things that are troubling people every day, and this has a real impact, right? These access issues in the healthcare service are leading to something like 200 to 300 excess deaths that could be avoided simply because people can't get to emergency services on time, to clinicians who are working in the A&E rooms. And I mean, there's also a sort of an impact on our economy, right? The labour market has 2 million people missing within it, and part of that is because people actually just aren't well enough to get into work. So this is a real problem. And the reason I've called it crisis mitigation is because there's only so much that we can now do about it. That's partly because we've dithered and delayed. When I say we, I mean the government. And as sort of Rishi Sunak has finally sort of grasped the nettle and said this is a priority and is thinking through it. But ideally, that sort of thinking would have come before we got into the winter. There's nothing particularly surprising about a wave of winter viruses in the winter, for example. Is obviously also a consequence of several years worth of political choices. Anyway, so that's the crisis mitigation. And the policy goal here, the goal of what a politician or the government should be doing is really quite simply to limit the number of people who are dying simply because they can't get access to timely healthcare. Now that sounds horrible, but that is exactly what it should be. And given how important that policy goal sounds, really that should be really at the top of any government's sort of in tray. You know, that should be the number one priority across government to some extent over the next few weeks. So that's the sort of immediate term challenge, crisis mitigation. Now, on the other hand, there is a longer term challenge here about reforming the NHS. And what's the problem here, right? Isn't it just the glory of the world, and doesn't the NHS do excellently? Well, actually, that's not quite true. The UK has the highest death rate due to treatable causes compared to any other country apart from the USA. When I say any other country, I mean comparable countries. So other English-speaking countries, Australia, New Zealand, Canada, other Northwest European countries, Germany, France, Austria, the Netherlands, and the Nordic countries. So these are countries we like to compare ourselves to. And actually more people in the UK die every year broadly because of treatable causes, which means things that could have been avoided if you got to healthcare on time or if you got good enough healthcare. So that's quite interesting. And that's not a new problem. That's a problem that's been going on for a while. It's probably something we don't talk about enough. And again, the impacts of that, I don't need to tell you, right? There's a clear health consequence of that, clear moral consequence of that. And it certainly will have an impact on the economy and the condition of our economy. So what should be the goal of policy in that condition, for that problem? It's something that I think political parties of all stripes and governments have tried to grapple with. And the broad goal here is to improve health outcomes, but to do that in a way that doesn't lead to an ever-increasing share of GDP spent on healthcare. And that's the sort of thing we try and try and work out how do we get to what good looks like, and can we do that in a way that we think is fiscally sustainable? So those are the two different problems, and maybe I'll just spend a little bit sort of thinking about each of them, and then we can take the conversation into a direction that people on this call would rather focus on. Right, so let's start with the that first problem, what I've described as crisis mitigation. What should we do over the next few weeks and months? And this is broadly an access problem, and access across the whole health service, whether it's seeing your GP, or whether it's going to A&E, or whether it's getting mental health care, or whether it's getting social care. There's an access problem, and these things feed on each other. So broadly what people in the health policy world call flow, and people in hospitals call flow, but what it really means is patients getting to the right bit of the system on time. The key bottleneck here, if I was a policymaker, I'd be focusing on opening up beds. So what we saw recently, I think this week actually, it was the government announcing a new sort of fleet of ambulances and money going into getting more ambulances, which sounds like a good idea, right? If 1 in 4 ambulances are taking over an hour to get to someone with a suspected stroke, why don't we just have more ambulances? The problem is that it's quite a naive way of looking at the problem, because you can have more ambulances and they might be able to get to people on time if you can find the right people to drive the ambulance. But then the ambulance gets in the A&E department, and there isn't any space in the A&E department. There aren't enough doctors and nurses in the A&E department, so it's just waiting outside the department. And that patient is not going to be seen any earlier, really, until there's more space in the A&E department. And how do you get more space in the A&E department? Well, that's broadly finding enough spaces in the hospital to admit patients to from A&E. And how do you find more spaces in the hospital? That's the big question. You can either find new beds, or you can open up existing beds. Finding new beds is pretty difficult. Can't just sort of build a hospital overnight with lots of new beds. Not impossible, but it's not easy. There's a conversation about private sector beds, but actually there aren't very many beds in the private sector anyway, and they're pretty much not evenly distributed around the country. In fact, they're very concentrated. So it's a bit of a red herring, to be honest. Even if you broadly believe that was the right idea, it's not going to make much of a difference. So the focus should be on opening up beds in hospitals, existing hospitals, around on any given week. And this is true of the pre-pandemic era too. Only around 40 to 50% of people who are medically fit for discharge is what people like me would say, which means that they're well enough not to be in the hospital, but they're probably not well enough to get dressed in the mornings or make themselves tea. They can't get home just because there's an inadequacy of sort of someone to make their tea, to help them get dressed. So that's quite easy to resolve. It's all about driving people into the care workforce so people can get the care they need, whether that's in a nursing home or at home. It's probably, I would say, it's probably an indictment of how we treat the care profession, that it only takes a week or two to train someone to become a care worker. But that is the reality in England today, which means it's potentially useful at this point in time. If the bottleneck is not enough people who are able to provide care to people in their own homes instead of a nurse having to do it in a hospital, well, then that's something we can probably solve in a few weeks if we really try to drive people into the care workforce. So that's one example of something we can do about the challenges that you're seeing in the newspapers and on the telly every single day. The thing that gets slightly less attention, but something that the opposition, the Labour Party, has been talking a lot more about is that, yes, we'll do something about what's going on now, but that's government's responsibility. But we need to invest and reform. And I think they have a point. I think there is something here about the NHS being a slightly outdated system, right? Something that's set up to treat illness back in the day when everyone used to get infectious diseases or get hit by a car, and things like chronic diseases that you have for 15, 20, 30 years of your life, they were quite rare. And so the health service hasn't quite adapted to be like, okay, well, how do we treat this new cohort where actually the most common diseases are high blood pressure or diabetes? And is the current setup, the current service organized in a way to best address those? And the answer to that is no, which has two consequences. We aren't very good at sort of having good clinical outcomes, sort of people dying of things like cancer and cardiovascular disease. Again, it's more likely here in the UK than it is to those comparable countries. And it costs us a lot more to do it as well, because we intervene at such a late stage. It's sort of, instead of preventing someone having diabetes or stopping the diabetes leading to vascular damage, we let the diabetes get to the stage where someone needs an amputation, and then we amputate their leg. That's not good for the patient, and it's not good for the taxpayer. So there is something here about how we run healthcare that we have to rethink about. And that's broadly what I think reform should stand for. It means something different to everyone else. To some people, it's about, well, is this about the single taxpayer funded model? To me, it's not. It's about how the service is organized. And there's all sorts of things like the how question. What do we do about it? That's pretty difficult, right? It's complicated. There's not one single thing. Oh, I'll just hire 100,000 more nurses and that will solve it all. I mean, that's part of the answer, and part of the answer is thinking about how we prevent illness, and part of the answer is the funding question and how sustainable funding could be, and part of the answer is about improving productivity and digital connectivity in the healthcare system. So there's all sorts of things that we're currently working on IPPR right now to try and sort of cohere into something that feels like project. If someone really wants to deal with this issue, what are the 1, 2, 3, 4, 5 things that you should do to fix this? And I'll probably, I don't know where I'm up to in my time, but I'll probably just end on like, what could the next 10 years look like for the health service? And I think there are 4 options. The first one is the sort of current trend continues. Health outcomes, clinical outcomes continue to get worse, and we keep spending more and more money on the health service. So there's sort of the worst of both worlds. Money goes in, and actually people aren't getting to see their GP any easier, and cancer survival hasn't improved. And that broadly, in my view, will lead to increasing numbers of people just opting out of the health service, the national health service, saying actually the quality is just not good enough. And if I go private, I can skip the queues. I can get access to something quicker, and I might be able to get access to a newer technology or newer therapy, which is sort of what we're seeing right now, these ideas of a 2-tier healthcare system. This is broadly what I think that means. And we've seen at least signs that that's the path we're on at the moment over the past couple of years. Now, this is a problem in my perspective, because in general, once you have an affluence-based opt-out, you then have a poorer quality service used by the majority, or the people who can't afford to opt out, and a slightly higher quality healthcare service used by the rest. And that will not only magnify health inequality, but also social and economic inequality. Separate discriminatory services for poor people tend to always be poorer quality services, said one of the great sort of social scientists, Richard Titmuss, back in the 60s, right? And the analogy that I find useful here to think about is the English school system. Everyone can go to a comprehensive school, but actually a certain segment, a sizable segment, 15, 20%, choose to go to a private school. And then there's nothing inherently wrong with that, you might say. And I agree, there's nothing inherently wrong with that. But then the sort of the consequences of that are played out across the life course in terms of the kind of university you end up to, kind of jobs that are available to you, kind of social networks available to you. Do you have a friend who has a second house in Marbella that you can go to? All these like small things that do sort of build up over the lifespan and do ultimately make a difference. I think that's quite a nice analogy to think about the path that you could argue the NHS is on at the moment. That's one potential future. Another potential future is that actually, again, the clinical outcomes keep getting worse, getting deterioration. And the government responds to that by saying, all right, well, things are getting worse, and I'm not going to keep plowing money into something that isn't working. So I'm just going to just restrict access. I'm going to start to charge people to see their GPs, for example, or I'm going to charge you if you don't turn up to an appointment. So we impose restrictions instead of like an opt-out from people who can afford to opt out. This is now the government topped out saying it's not available to certain people. And that undermines the universal principle that basically is clear in the NHS and not clear in any other public service. And again, you have the same problem there between sort of discriminatory services between different people. The coalition of support around the NHS is destabilized, and it's quite hard to see how that plays out, but it's probably not going to play out in a pleasant way. The analogy here that's quite useful is dentistry or optometry or social care, right? These are sort of means-tested public services broadly. And there's all sorts of problems in all 3 of those things. The last one that I think a lot of people quite like to grasp onto, that I'm a little bit more skeptical about, and maybe this is more controversial, so we want to talk about this, which is that let's say clinical outcomes get better. So actually the NHS improves, and we get much better at treating cancer and heart attacks, and people are surviving longer, and the healthcare system is doing what we want it to do. But the problem with that is the way we've achieved that, for example, is to just keep plowing ever rising share of GDP into that. Sort of 50, 60% of taxpayers' money is going on the health service. Now you might say that's no bad thing. That's kind of what we need to do for an aging population, right? But actually I think that's not true, because if you're going to spend 50 or 60% of taxpayers' money on healthcare, then other public services are going to miss out. And that's self-defeating. It means less money for schools, less money for social care, less money for public housing, and the whole gamut, less money for local governments. That will ultimately undermine the health benefits in the short run of having a better performing healthcare service. So there's trade-offs there. So two-tier means testing trade-offs, all bad outcomes, in my opinion. So what's the one we need to hit? That's the one where we actually manage to improve clinical outcomes, and we do it with a sort of stable GDP growth, not something ever rising, so we're hitting 50, 60% of taxpayers' money on healthcare, but something that's reasonable, still high, but like something that we feel that we can afford and continue to fund. And I think that should really be the challenge, essentially, of policymakers.